Welcome to The Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm your host, Dr. Andrew Wilner. Today, I'd like to welcome Dr. Susan Landers. Dr. Landers is the author of a new book, So Many Babies, about her struggle to balance life as a mother, wife, and full-time neonatologist. But before we get started, I'd like to thank all of my viewers on YouTube and listeners on podcast players. The Art of Medicine with Dr. Andrew Wilner has been playing now for over 3 years, and it's really taking off. So I want to thank you. Please share it, and thanks for being here. I also host other programs, and to never miss any of these, please sign up at my website, andrewwilner.com. You'll get a blog, announcements. You don't have to do anything with them. You could discard them, but you'll get links to all the programs. And now I'd like to thank our sponsor, locumstory.com. Maybe you're curious about locums and how it might fit into your career story, but do you know all the different reasons physicians choose locums and how it works for them? At locumstory.com, you can hear firsthand stories as diverse as physicians themselves. There's not one solution for everyone. The variety of opportunities might surprise you. Locum Story is an unbiased educational resource. It has tools that let you explore trends in your specialty and compare different locums agencies. There's even a simple quiz to see if locums is right for you. Do your own research at locumstory.com. It's easy. Okay, and now to my guest. I'm very excited to talk with Dr. Landers because I read her book. I've got a lot of questions. Welcome, Dr. Susan Landers.
Thank you, Dr. Andrew. I appreciate the invitation to speak with you.
You know, one of the reasons I do this podcast is, well, I'm a writer myself, and I love to speak to authors. And I have many authors on the program. Not every guest has a published book, but probably more than half. And of course, authors who are physicians are of a particular interest to me. That's always been my kind of evolution personally. And frankly, it is a difficult thing to do because balancing writing, which if you're not a writer, it looks easy, but if you are a writer, it's not. And it takes a lot of time. And being a good doctor takes a lot of time. And being a good mother, parent, I don't know about mothers, but as a father parent, I know it takes a lot of time. And I know that the mother half of my family puts in even more time. So, and your book, I think, very honestly approaches these challenges of balance. So tell me first, why did you write the book?
After I completed my career, 34 years in the NICU, neonatal ICU.
Neonatal. So just tell us briefly before we go too far, what's a neonate?
A neonate is a baby that's 1 month old or a newborn baby. And generally we take care of sick and fragile premature infants and any newborn, full-term newborn infants who are sick after birth, and take care of children throughout the first month of life. After the first month, sick infants generally are cared for in the pediatric ICU, but the neonatal ICU is for the babies. And it's just like an ICU for big people with ventilators and drips and medicines and one nurse to one baby and special therapies. But it's for babies, not big people.
And arguably, I think I spent a fair amount of time in the adult ICU, but you know, a premature infant is probably at least as fragile, if not more fragile, than an 89-year-old, you know, with a subdural hematoma or sepsis. It sounds like that's a very difficult, and consequently, I think that probably translates to stressful day. Is that right?
Right. Right. Well, some preemies are stronger than others, and some are more immature than others. But preemies that are fragile or sick can stay in the hospital 4 to 6 months, typically. The sickest ones will stay in the hospital up to a year. And some are transferred to the pediatric ICU because they're trached, they're on a ventilator, they have chronic lung disease, or they have some neurological problem that prevents them from going home. So there's a wide range of children, babies that we take care of in the NICU, from an infant born a few weeks early who just has a little breathing problem and that gets better in a week, to a premature who stops breathing every time he falls asleep, to a baby with overwhelming bloodstream infection or meningitis. So it's a serious thing. And parents who have a baby in the NICU are completely overwhelmed. It is always a shock. Probably unlike the adult ICU, when grown-ups get sick, they kind of know they're headed to the ICU, or they're told they're going that direction. But when a mom has a sick premature baby or a newborn that gets sick, it is a shock. It is a surprise. It is a major trauma. And I think we deal with people who are shaken up, family and loved ones who are staring at this small, fragile, sick baby going, oh my God, how did this happen? Perhaps in an adult ICU, it's similar. But there is this almost surreal notion that parents tell me about when they're looking at their baby lying in this bed, hooked up to these tubes and wires and on a ventilator. And they'll look and they'll say, is that my baby? That can't be my baby. I know I birthed it, but it's not mine. I can barely even touch it, much less hold it. And so the shock is something that we learn to deal with and learn to give parents space to cope with and learn to help them along in the journey. Sometimes that journey goes really well, and other times, unfortunately, it's a horrible place where they end up losing their child.
All right. Well, this is pretty interesting. So let's take a step backwards. This was your goal, to spend days and nights with these sick babies and worried parents. Now, is the formation for this, the training, are you a pediatrician first? Is that the way it works?
Yes. After medical school, you do 3 years of pediatric residency and then 3 years of neonatology fellowship. So it's a 6-year training total. I fell in love with the critical care aspects of neonatology, and then working with moms and babies and breastfeeding and things that mothers and babies talk about solidified my passion in that area. It's not like obstetrics. In obstetrics, the goal is to get the mom delivered. In neonatology, the goal is to heal the baby and get them to thrive and go home with their mother, with their family.
And bonded.
Yes, absolutely. It's pretty hard to bond to a baby that's hooked up to wires and tubes and not awake, not responding. So the mom has to come at that gradually. It's very traumatic. The mothers describe it as very traumatic, very shocking. And so I always felt this sort of additional calling besides caring for babies, which is fun in a way. It's exciting. It's intensive care medicine. You see results really quickly. It's very rewarding, but dealing with the moms, especially dads too, takes more time, more finesse, more presence, more being at the bedside, more encouraging them to hold, to talk to sing to their baby, more times convincing them that yes, they can hold their baby who only weighs 2 pounds and is hooked up to a ventilator. And yes, they need to pump their breast milk for 8 weeks or more before their baby will be able to nurse at the breast. So the challenges of that particular patient population, I found amazing and wonderful because there was so much we could do to help.
Okay, very inspiring. You chose this demanding profession. But what about the other side? We talk a lot
Yeah.
about work-life balance. Was this compatible with
No.
you having a family and children of your own, and the whole your personal life? How did that work out?
Well, I finished my training and became a neonatologist before I was even married, later at 34 years of age, and had children at 35, 37, and 40 years of age. So I knew how to be a great doctor, but I really stumbled and fell a lot in my trying to be a great mother. And like so many women in medicine today, I struggled to figure out how to be at work when I was there and not worry about the kids and make sure they had the care they needed when I was at work, but be at home with them in my days off and not worry about that little sick preemie, give it to somebody else who was on call in the hospital. But I'll tell you, Andrew, one of the things I tell a young women physician now is imagine what you will be doing. Imagine how you will be practicing in your mid 40s. And most people don't think about that in their 30s before they're married and have kids. The way you practice medicine has to be compatible with your life as a mom, as a wife, as a spouse, with children, with a life. And so the hardest thing for me was learning how to do that. It was hard to learn how to be a working mom and have days off with my family. It was hard for me to learn how to take care of myself, how to use my friends for a support system, how to take care of my marriage. Fortunately, I was married to a physician, a pediatric nephrologist. So he was, he was comfortable with chatting about patients and he understood what I was going through. But he didn't work as hard as I did. He didn't work on call in the hospital at night like I did. However, when I was away at night, I knew my children were in good hands with him because he was a good dad and a pediatrician to boot. So I had a good deal in my marriage and with my family, but it took me about 10 years to learn how to juggle work, call schedules, projects, children, the appointments, their activities, their sports, all of that, the regular working mom kind of issues. It took me a long time to make that work.
All right, I got a lot to say here. So first of all, you had 4 years of medical training, 3 years of pediatric residency, and 3 years of neonatology to train you to do your profession. So that's 4 plus 3 plus 3. So you had 10 years of training, pretty intense training, by the way, not just 8 hours a day.
Right.
And training to be a mother, you had 0 hours.
0.
Right?
Right.
So
exactly.
It's no surprise that it took you a while to catch up. I think the other point that you make in your book, and that I'm aware of too, is that the medical environment, and certainly in our generation, it was probably more so, was not sympathetic to demands outside of the hospital.
Oh, no.
The term
no.
resident refers to being a resident in the hospital. Even in the old days, my generation before us, you weren't supposed to get married.
Right.
You're not supposed
to live
to
in the hospital.
You lived in the hospital, 100% of your energy. You're like a Navy SEAL. Your family, you have one, that's fine. But let's focus on what you got to do here. And of course, that is evolving, but I would say very slowly and painfully, because the system runs 24/7. And if if your child gets sick and has to stay home, I mean, 3 years old, it's like, well, I can't bring him to the NICU. What am I going to do?
Right.
And your husband's working.
Yeah, childcare responsibilities are crucial for medical doctors who have children. And spouse and partner relationships are crucial. You can't pull off being a full-time medical practitioner unless you have the other aspects of your life under control, taken care of. I have to tell you a great anecdote. When I joined my practice in Austin, it consisted of 9 men, all male neonatology practice. I was the first woman they hired. I knew some of them from fellowship in Houston, so it was easy to know what sort of personalities and character they had. But after about 6 months of starting every day at 7 in the morning and working shifts until 7 in the evening, I brought up in a meeting, hey guys, could we maybe start at 8 and maybe end at 5 or 6? Because to start at 7, I have to get up at 6, leave the house at 6:30. I can't get my kids dressed, ready for school and on the bus. I don't even see my kids. And if we get off at 7 p.m., I can't even get there and put them to bed. And they were all married to stay-at-home wives, stay-at-home moms. And they looked at me like, what do you mean? And we talked about it, and some of them grumbled, and we decided to switch to check in at 8 in the morning, check out at 5:30 in the afternoon. 3 months after this change, 4 of them independently came up to me and said, thank you for doing that. I had breakfast with my kids. I love it. Sometimes my wife lets me drop them at school on the way into work. And they realized what they had been missing by zooming into the hospital to start at 7 every morning and staying late to finish at 7 at night. So it took a little bit of a mother's mind, a woman's mind, to sort of say, hey guys, there's really an easier way to do this, thinking about the other parts of our lives.
I'm going to read a quote from your book. It's a short paragraph here. Because part of our purpose today is we're speaking to a lot of young physicians and young female physicians and male physicians, as well as non-medical people. And so I want, based on your experience, I think you're in a great position to give some advice. So here we go. As much as I loved being a physician, as much as those skills made me feel competent, as much as practicing neonatology gave me a sense of importance, I have concluded that I received infinitely more joy in knowing, raising, and loving my children than I ever did from practicing medicine.
That was a hard sentence to write. When I wrote my memoir after I retired, I did a lot of self-analysis. I was pretty burned out at the end of my career. It sort of snuck up on me in my early 60s, and I retired by age 64. And so I wanted to sort through what meant what to me in my life. And as much as I loved medicine, I realized that I loved my children more. And I often wished, and you can tell in the book when I write stories about being a working mother, I wish that I had spent more time with my children. I wish that I hadn't worked 60-hour weeks. I wish that I hadn't missed the occasional swim meet or soccer game. But having said all of that, and all working mothers feel that way, the joy and the struggle and the real life experience that we get from being parents is really, to me, even more fulfilling than the hugely rewarding experience of being a physician. And they're both just wonderful. They're both just totally wonderful. My kids aren't all perfect. They had plenty of problems. And I lost patients. Every physician loses a patient now and then. But when I stacked up my career and my being a mother side by side, it was being a mother that had been more fulfilling for me. And so I want women physicians who are younger, who plan to have a family, have children, to think about what they want to do in medicine so they can also have a family.
I want to talk about a strategy that occurred to me while reading your book. When we went to medical school, there was this concept, and you talk about it in the book, and that a really accomplished physician should be a clinician, a teacher, and a researcher. Have an academic career, publish papers, go to meetings, be great on the wards, know what to do, know how to deal with parents and doses, and of course, have residents and students trailing behind them. That's sort of the idealized image, and for I think that is how our icons, the William Oslers of the world lived. I did a program. An interview a couple of years ago on this program with a fellow who is a researcher and clinician at one of the Harvard hospitals and does all those three things. And we talked about it. I said, I've tried to do those things personally in my life. And frankly, I haven't really succeeded. I think I'm a pretty good clinician, and I think I'm a really good teacher. I do some research, but it's certainly it's the Nobel Prize is never going to happen. I'm not going to be on that. Even the list of possibilities, I'm not in that ballpark, and I feel like a failure. And we talked about that, and he said, you know what? He said, these days, that goal is impossible.
Good.
And the purpose of our conversation was, that's right, because it is unfair. I think it's very unfair to teach the medical students and residents that you should aspire to that, because research has gotten way more complicated. Clinical medicine has gotten way more difficult because you have many more options for treatment, and there's new diseases and people are sicker. In the old days, you just sat by the bedside and took their pulse and, said nice things, maybe gave an antibiotic, but it's way, way more complicated now. And teaching also is a special skill. You don't just look, you're not, some people are born teachers, but most people have to learn how to do it. So I think one sort of practical piece of advice to young physicians is that you do need to choose. If you want to be an academician, right, that's great, but you cannot also expect, in fact, we used to say this when I was a resident, some of the great academicians in my program who were world famous, you didn't really want to round with them because they weren't helping you that much at the bedside, because that wasn't what they did, 12 hours a day. They only did that like 2 days a month. And it showed, the rest of the world didn't know that. But, us insiders knew that. So do you agree? Do you think you really have to choose between those three?
I do agree. And based on my personal experience, starting off in academic medicine, once I had children and was establishing my career, had been promoted to associate professor, had 30 some odd papers, I came to the point in my mid-40s of realizing that I could not do it all. I could not raise 3 children, enjoy my marriage and my family, and keep up with all the research that I was attempting to do and write the papers and teach and make rounds. And I was in a particular setting where the clinical requirements were really stiff, and lots of night call, lots of, work 12 days in a row before you get 2 days off. And I ended up having to choose. And I said, I can't do this anymore. I love teaching, but I just gave the research up. And my husband and I both moved to private practice. And it was way more fulfilling because I was more focused on what I was doing, and I had more time with my family. I did feel like a failure a little bit for a while. And because, I had these icons in my mind. I wanted to be like Carol Baker. She was devoted to pediatric infectious disease, had beautiful NIH grants, worked on Group B strep, she never was married and had children. And so I was even comparing myself to someone that wasn't even like me. And so I think that in medicine, we tend to set our expectations so high, and our negative self-talk is so loud. You ought to be able to do this. You ought to be able to do it. And we hear it as interns and residents. You can do it. You can work 18 hours in a row. God, you can work 30 in a row. We did it. But nowadays, we're giving ourselves permission to say, what is important? Research might be important, but maybe you don't do as much teaching or as much clinical work. Somebody's got to do good research, and somebody's got to be good at clinical work and teaching. But you don't have to do all three anymore. And if you want to have a family, I don't think you can do all three.
I agree. I have a question as a husband. Your husband doesn't get a lot of pages in your book. Now, is that because this is a women's book, or you just want to protect his privacy? Or I was curious because you mentioned him. He's sort of but he's way, way, way in the background. Was that your relationship, or is that just how you chose to portray him?
I chose to portray him as my helper and my confidant and my supporter, but not get into his life and our marriage that much. I do get into our marriage a little bit, especially in my 40s. He didn't really want to be a big part of the book. He wasn't even behind my effort to write a memoir. It was the girls in my book club who said, if you're going to write about Nikki's stories, you've got to put your mom's stories in there. And I said, oh, really? Oh, yeah, that'll make it so much more interesting. If you tell all these stories of being a working mom, how we all rush from one thing to the other, how we try to juggle everything in our lives and hold down a full-time job, that's going to be way more interesting to other women. So as I wrote the book, I was actually thinking about the other women that my story might help. I thought that if I was honest about the mistakes I made, if I was honest about the challenges, I had the worst adolescent. God, my third child was the adolescent from hell. She was horrible. And if I hadn't told the truth about that, other mothers might think, well, it's just me. Something's wrong with me. I mean, two of my kids were great adolescents. The other one was terrible. Wrecked cars, skipped school, smoked dope, the whole thing. She did everything but get pregnant. And I was totally unprepared for how to take care of this kid, how to reach her, how to help her. And so I tell stories that are true, that are vulnerable. I'm a good fan of Brene Brown. I really believe in being vulnerable and admitting to my own shortcomings, because I think that makes us more human. I wanted to seem human as a physician and a mother. I wanted to seem real. And so by not focusing on him, I focused more on myself. Maybe that was a little selfish, but I had to focus. And it's the working mother part of it that I wanted the message to be.
I'm sure you appreciated being left out. It's not a problem. So you've answered this partially, but who should read this book?
I think young physicians should read the book, men and women. I think people going into critical care field should definitely read it. I think working mothers who have high stress jobs should read it. Nursing is a stress powder keg these days. A lot of C-suite jobs, professional, executive moms should read this book. I've been told that it's really just a book for old women who like memoirs, but I don't believe that. I think my book I've heard from a lot of young working mothers. I think my book is reassuring to working mothers that what they're doing is really hard. We know that being a doctor is really hard. People know that. I think they've watched us work until we, drag in the door. But I don't think people understand how hard it is these days to be a working mother, full-time working mother. We heap so many responsibilities on ourselves, especially physicians. We want to do everything perfectly, and that is just not possible. So I want working women to know that it is fine to have to choose between your sick child and your job. It's fine to have to work on a project and miss a play at school. That's what life is all about, making those decisions. But it feels so difficult in the moment. And so I want my book to tell working women that it is okay to feel what you're feeling, because that's what we're doing.
Well, I've read your book, So Many Babies, and it's on Amazon. And I'm not a working mother, but many of the issues resonated with me,
Oh.
as well. We're recording this, and in about an hour and a half, my son's going to come home from school. But I need to edit this program, and that's going to take me about 2 hours. So I'm going to have to decide whether I run downstairs and greet him from coming home from school, or whether I sit here and continue to edit it while everything is fresh in my mind. Hopefully, you won't know the difference if that doesn't happen. But yeah, I mean, these decisions for a working mother are just constant. And God forbid your kid gets sick, you can't go to school that day, or you have a doctor's appointment, or you got to prepare lunch. I mean, it's just endless. And so
Mm-hmm.
I think being frank about it is helpful. And maybe thinking, more realistic uh, objectives when it comes to a career. I think
Mm-hmm.
uh,
Mm-hmm.
I think you point out those things really well in your book. Okay, well, we're just about out of time. Anything else you'd like to add before we close?
I love what you're doing and talking about the various aspects of practicing medicine and the art of medicine. The only thing that I regret in my career is watching people becoming less tolerant of diseases and death and dying. I think as a culture, we are not accepting that disease happens, and sometimes death is a normal part of our human experience. And having sat with many parents while their baby dies has really taught me that the intimacy that we find in those family relationships, especially with being a medical practitioner, is just wonderful. And I want people to just remember that their physician is working with them to help them, but we are not gods. We cannot solve every problem. There are things that don't get better. There are bad things that happen to people, even little babies. And sometimes we lose a patient, and that hurts us too. So I just want people to remember that doctors are human too, and that we're born wanting to help and serve others. And I'm just asking for people to be nice to doctors and nurses. Ever since the pandemic, we've all sort of gotten a bad rap, but we're just out there trying to make a difference.
Well, Dr. Susan Landers, author of So Many Babies, I want to thank you very much for joining me on The Art of Medicine.
Thank you, Dr. Wilner.
Now, before we close, I'd like to give another thanks to our sponsor, locumstory.com, a resource where providers can get real, unbiased answers about locum tenens. I'm Dr. Andrew Wilner. See you next time.
This program is hosted, edited, and produced
by Andrew Wilner, MD, FACP, FAAN. Guests receive no financial compensation for their appearance on The Art of Medicine. Andrew Wilner, MD, is Associate Professor of Neurology at the University of Tennessee Health Science Center, Memphis, Tennessee. Views, thoughts, and opinions expressed on this program belong solely to Dr. Wilner and his guests and not necessarily to their employers, organizations, or other group or individual. While this program intends to be informative, it is meant for entertainment purposes only. The Art of Medicine does not offer professional financial, legal, or medical advice. Dr. Wilner and his guests assume no responsibility or liability for any damages, financial or otherwise, that arise in connection with consuming this program's content. Thanks for watching. For more episodes of The Art of Medicine, please subscribe. www.andrewwilner.com